Welcome everyone to another episode of Beyond the Exam Room, and we're so excited to have Kristin Satsky. Is it Satsky?
It is. Satsky.
Okay. It's not Polish, right?
Czechoslovakian.
Czechoslovakian, I would think so, because Polish is typically a ski.
Yes,
SKI, right?
Right.
Yeah, that's what I'm sorry about that.
You're good.
Anyway, she's a licensed clinical social worker, but also her major title is Chief Operating Officer for Halcyon Home,
Yes.
which has home health, hospice, and what other services do you have? Caregivers.
Mhm.
Oh my gosh, you have all three, which is phenomenal.
Yes.
So we are very excited to have you here and welcome.
Thank you.
Okay, so why don't you tell us a little bit about your journey, how you got into this space?
So as you mentioned, I am an LCSW.
Right.
So I started out in social work in home health.
Yeah.
And started to realize that physicians didn't know what social workers were doing in home health. And so I started talking to physicians about what care I was providing for the patients.
Mm-hmm.
And started to learn a little bit more about other things that our staff were doing, our nurses, our physical therapists, occupational therapists, speech therapists. And in that, started educating physicians on all of it. And moved into more of a sales education role, and then into leadership positions. And over the last 25 years, just have had the opportunity to touch a lot of lives, including employees, but also patients, providing home health and hospice care and caregivers throughout those many years.
Appreciate you, because I really want to get into your insight because of the journey that you've gone through. You know, I've always said, anyone who's been watching my podcast, that I'm very passionate about, our seniors and our frail people being taken care of at home, right? And if you look at the health ecosystem, it's very clear. If you look at the data, it's not even close. Where you get the most bang for your money is how you deliver good quality care at home, right? And it's just very difficult, even in this day and age, with all the technology that we have, that we don't leverage home care as much as we want to, right? A prime example, I still don't understand why, we still have patients at MedSearch 1 in a hospital, right? Well, what's the point? I mean, you can monitor everything that you want at home like you do in a hospital facility, right? You agree with that?
Yes, absolutely. And we've taken it one step further. So traditional home health provides nursing and therapy services. We also have remote patient monitoring.
Exactly.
So we put the modality, the vitals measuring machine in the home, the weight, the scale, the blood pressure cuff, and they take their own vitals daily, but that information is transmitted to a registered nurse, and she looks at the data and then tells us if we need to do a visit.
Right.
And so that allows us to perform daily visits when the Medicare regulations have decreased our number of in-person visits that are allowed. So it really is a necessary tool to make sure that we're doing something a little bit more innovative than just in-home nursing and therapy.
Yeah, I mean, we keep saying it's innovative. In my book, I almost feel like we're going backwards in the fact that really the old Marcus Welby days, do you remember that? Did you ever? You're too young for that.
No, I'm not.
Yeah, Marcus Welby was a doctor, and I grew up watching him, and he would do home care visits. He would visit.
In-home visits.
Yeah, in-home visits. He never had an office. He went to the home and did the care. And if you look at the data, it's very clear that's the way to do it. And obviously, it depends on the patient population, right? But especially in the sector that you and I live in, which is especially the elderly and the frail, the problem with, I see it, is that when you try to take care of them, almost like a photograph, and this is a good analogy I always say, you can't take care of the most vulnerable population, the elderly and the frail, by just doing photographs. And so they go see the cardiologist and you take a photograph, and then they go see their primary care and you take a photograph, and then they see another specialist and they take a photograph, right? And there's so many things missing because that 15-20 minute visit, there's nothing collaborative about that. For those kind of patients, in my book, we need a running documentary, right? And the best way you can do that is the services that you provide.
Absolutely.
Right? The input that you get from your nurses and people that visit the home, just give us some of the insights on that.
Well, so you mentioned a few things. So our CEO, we are privately owned, and she started out doing home visits herself. So she's a physician's assistant, and that's how she started her practice, was doing that. And so she saw the need of really making sure that we were touching people and really reporting that back. So with our core values of communicate and collaborate, we make sure that we really are talking to all of the physicians involved, not just their primary care doctor, but all of the specialists that are involved. And we're also regulated to do so now. So under Medicare new regulations, it's called value-based purchasing.
Right.
We have to communicate in order to provide the best outcomes and prove that in order to get reimbursed what we deserve. And so as a result of that, it's really important that we are documenting everything really well, communicating that back to you, communicating back to all the specialists, and then making sure that we're adding care if needed.
Yeah, and that's the core, right? When you're visiting them at the home, that's where you actually see everything that occurs. And to me, that's where almost all the things occur. And when I'm talking to people who are either care providers or caregivers, you know, one of the big tasks that you do is what you talked about is observe, document, and report. Those are three vital aspects that is absolutely crucial to manage a patient well, and that's one of the hallmarks for you guys, the services that you do, right?
Definitely. Well, and as a social worker, I used to always tell my friends who were social workers, they'd say, well, why do they need home health? I'd say, because how do you know what you told them at the hospital or what you told them in a physician's visit that they're actually doing it? The only way you know is if you send someone to the home to make sure that that's happening, that can open their cabinets, look at their food they're eating, put all of their medications out and say, oh, you had this last visit, you had this after this doctor's visit, you can't take both together, really, and then letting you know, oh, we noticed they have 2 bottles, because we can be your eyes that you can't be.
And ears too.
Yeah, and ears too.
Oh, absolutely.
Yeah, absolutely.
So I love the fact that you have all 3 services, that you have home health services, you have caregiver services, and then you have hospice.
Yes,
right?
and we also work closely with palliative care.
Right, palliative care. And those are 3 different buckets. So, so tell us, for example, like if we ask for home health services, what does that entail? What services can you provide at the home, and what service can you not provide at the home?
So home health services cover skilled services.
Right.
So skilled nursing, physical therapy, occupational therapy, speech therapy, and an aid if they need it, but for minimal visits. So they can help with bathing and dressing maybe twice a week with a shower.
Okay.
That is covered 100% under Medicare services, those skilled services. They require a physician's order, and if you are not sure if you qualify, basically you can call any home health. Our home health number is answered 24 hours a day live, so we would be happy to do an assessment, but you can call any home health or start with your physician and ask them, hey, do you think I qualify? But to qualify, you need a changing condition for that skilled services under home health. For caregiver services, you don't need anything but a need. So maybe you need a companion, maybe you need someone to take you to the doctor's appointment, to a surgical appointment, to maybe your care has extended to the point that you need someone with you 24 hours a day. We can do 15-minute med reminders up to 24 hours of care, and that's under private pay. So whereas the skilled services are covered under Medicare and some private insurances, the caregiver services are covered under long-term care and private pay.
So the caregiver services are non-clinical.
They are non-clinical, but they can be clinical.
Okay.
You can also pay privately for a nurse or a therapist if you want additional care than what's covered under Medicare. Okay. Medicare requires that we meet certain determinants to make sure that we're providing the care that follows their guidelines. So they will give us a recommendation based on your diagnosis. If you say you have CHF, they may tell us we can go out twice a week. If you wanted additional services over than that, then that would be the private pay services.
Yeah. Okay. So with all the experience that you've had over the last 25 years, what would be the one single thing, if you could change in our healthcare system, what would that be and why?
I think it would be the communication. We still are, I want to say, in the dark ages with being able to communicate and find records easily for one another. So I would love to be able to receive a patient and be able to see their entire history and not have to just see what we are given. We constantly are unsure of their comorbidities and really what their history is, and they aren't always sure. So really understanding that, and I think we're getting there, but we still don't have a great communicator between all forms of medical care.
So you still feel like the healthcare system is pretty much siloed, right? Yeah, and just like me, we're hoping that AI can solve some of those problems.
Absolutely, and we've started to look at some of the AI tools for our documentation and helping our nurses to document easier and quicker. And so we are looking at those things. We also have overlays where we are looking at helping our clinicians to understand the regulations a little bit better. But I don't know if I see AI tools yet in communicating, like primary care doctor to cardiologist, cardiologist to home health to hospice. those sort of things that we could just put in a social or something and
Yeah.
have full access.
Yeah, it's difficult with something called HIPAA, but yeah, we're
Yeah.
going to get there.
Yeah.
The other part is like when you have a caregiver or a clinical person go into the house and they have certain concerns, right? It could be safety concerns because, I mean, I always tell people you have no idea what the patient is going through until you walk through that front door, and I've witnessed it myself. And so when they have those kinds of certain concerns, what's the best way for them to communicate that to the primary care physician?
By calling. So they just pick up the phone and call. That's what all of our staff are encouraged to do immediately.
Okay.
And so they call during that visit. We also have case management staff who communicate, of course, by fax and by written communication. Right. But when there's a concern, immediately we call.
Okay. And then have you noticed that they run into a lot of red tape, or are they able to get the primary care physician readily?
Depending on the physician, but we are able to communicate pretty quickly.
Okay, that's really important, right? Because sometimes that time will make a huge difference. Either they'll end up in the emergency room, or they can bring the patient into the clinic and really fix the problem, so to speak,
Yes.
temporarily. So I think that would be a really important piece too, how you can communicate with a primary care physician in that network. So to me, I'm just trying to figure out a way how we can get the home care services linked much more synchronously, so to speak,
Yes.
seamlessly with a primary care physician, because
Yes.
that would dramatically
It
decrease the cost of care,
It would.
right?
And one of the things, I heard one of your other podcasts where somebody was saying that home health don't necessarily go out after hours. That is something that we do and we pride ourselves in. So we avoid hospitalizations all the time by sending a nurse out.
Yep.
If sometimes 11 p.m. we have to send someone out because they've called our triage system. But it would be great if we had access. There was some sort of, I don't know, texting line or something with the primary care doctor that we could communicate.
Yeah, I would love to figure that out with our group, because it is really, really impactful for me. Anytime we have the ability to have eyes and ears in the home, to me, that's invaluable. It's absolutely invaluable. And so, one of the things I tell people, like when somebody had a acute chronic condition, let's say congestive heart failure, something very common for everyone, and then they go to the hospital, and then they get released from the hospital directly to the home instead of a post-acute facility, I always order a home health. And the reason for that is because I love the fact that they have eyes and ears in the home, right? And what people don't realize is when a patient gets discharged with chronic condition at home, that's not the end. That's the beginning of where you're going to have to realize that we have to do whatever is necessary so they don't go back, right? And I wonder why, in my opinion, why do you think primary care physicians or physicians in general are reluctant to do that?
I don't know. I think it's the work-life balance. We are all under that challenge at times that people start to think I'm working 24 hours a day. But I think you can put fail-safes in place where you're not the only one working 24 hours a day, and that's why there's larger practices. But what I've seen is that I know with my personal physician, I was disappointed recently to discover that there wasn't an on-call service anymore. And so, I think that things have changed with people needing more time or having less people available to manage those phone calls. But I agree that we can get better.
I think so too. But for me, because of that, when I order home health services, I feel much better because it's like an extension. Someone's going to go there and see and hear, and I can get feedback. Because obviously I don't have the bandwidth to go to their house if I wish I could. But the way I look at it is they're like my extension and then get information back. And so I don't know why that should almost be an automatic for somebody, who's got chronic conditions. If they get discharged from the hospital, it should to me, in a
Always
clinical
have home
workflow.
health.
Absolutely. I couldn't agree more.
Couldn't agree more.
Yeah, that would really, really be impactful. Other part that I want to ask you is, it's very difficult for you guys with the amount of dementia patients growing, right? And so I always wonder how does that work when you actually get called by a physician to go visit a patient who's got moderate to severe dementia. So, like, that's got to be pretty difficult. So, how does that work?
So home health is approved for dementia
Right.
as long as we are doing training.
Right.
So we can train the caregiver. We also can provide speech therapy in those beginning phases and train the client and
Right.
the patient. It does become challenging as they become less mobile. However, in those cases, we can continue some therapy and then add like caregiver services, aid support, even hospice care if they need it. And so it's just, it is a challenge that we go through, but I feel like one thing that we do really well with Halcyon is manage that population because our owner started in that population and assisted living herself, working with that population. Mm-hmm. So we do a lot of dementia training. We have dementia certified caregivers. We train our nurses on what they're looking for, what signs and symptoms, but also how to manage the concerns the caregivers are coming up with and how to deal with that.
So how about if there is no caregiver? Then it becomes very difficult,
yes,
right?
Yes, and so in those cases, we have oftentimes their care is managed by someone remote. Right. So we work with that person to arrange caregivers in the home. Oftentimes they're told they can't be there alone any longer. So we are giving them an opportunity to stay there with that 24-hour care, or we can assist with placement. And we work with a lot of skilled nursing facilities, assisted livings, independent livings, communities throughout all of our areas that we work, that we can get people placed pretty quickly if there is a true challenge that they're under and it's imminent.
Yeah, one of the challenges I have being a geriatrician is that we run into, unfortunately, too many cases where patients, they don't really plan, right? Mm-hmm. Nobody really plans very well sometimes for what's going to happen, quote unquote, end of life issues. Yes. And obviously, if they don't have any significant others that's going to help them and they themselves are getting dementia, it's a very difficult situation for us as well. And I always try to, what I always try to do is find as many resources that's available in the community to help. But, you know, what would you recommend in those kind of situations? What's the best way to handle something like that?
Well, and I haven't mentioned the service social work, but we do still provide social work under home health. Okay. And that is something we would send our social worker out to provide those resources and really advocate and determine, can they live alone? Do they have caregivers? What does their support look like? I will say, being a social worker myself and practicing in those settings, there were times that I felt maybe the person wasn't safe to be in that environment, but it's still their choice to reside where they want to reside, and all we can do is make that safe as possible. So providing that, increasing the nursing visits, the physical therapy visits, speech therapy visits more frequently in those cases until they are ready to make the decision to either increase their caregivers or move into a facility where they could be managed better.
Yeah, I call them almost like the lost people that nobody wants to kind of deal with because it's so difficult, right?
It is.
And that's the space that I think you and I live in a lot. Mm-hmm. And so I guess what I'm looking for is
an answer.
Yeah, an answer. Like, what do you think what we can do?
You know, I really don't have a quick answer, but I do think that, you know, in a personal instance, there was an individual who finally discovered the reason she did not want to leave her home was because of her fish. And I was able to find a facility that would take her fish, finally. And that was, but no one had ever discovered that was why. And so, you know, being able to provide those caregivers, and if someone can afford that and provide that in their home and stay there with their fish and their animals and live alone with that 24-hour support, that's wonderful. But if someone can't afford it, then the answer has to be moving to a place where they can be well taken care of.
Right, which is very difficult.
Can be challenging.
It is, but I love that story because it just goes right to the point where we really don't know what the situation is until you actually go in there and really ask the questions. Yes. And that is I love that story about the fish. Really, and it's so true. People who live in the space like you and I do, that's what it's about. It's about actually making the connection and actually getting to the bottom of what's really driving their behavior.
Absolutely.
You know?
I don't know if anyone ever asked her why she didn't want
I guarantee they did. I absolutely guarantee you they didn't do that. And that's why I'm a huge advocate for home health. I think anyone who has doubts about it, I would ask all of you to do your research and the value they create in the community. So I just want to thank you again for being here.
Well, thank you for having me.
And thank you for all the services that you do. And we're so blessed that you're in our community.
Well, thank you.